And welcome to the Dr. Bob Show. Ooh, what are those spots on my hand? Spots on my head. I feel a little lump right here in the skin. What are those lumps? Are they dangerous? Do you need to have them looked at by a professional? Can you just wait and watch it maybe and see what it does? Or could that be something that would be cancerous and that could continue to grow and you find it or you go to the professional too late? We'll be spending most of this show talking about spots on the skin and what we need to do about them. My guest is Dr. Meredith Overholt. Dr. Meredith Overholt is a board-certified skin specialist, dermatologist, and she answers these questions every single day. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. We'll be learning about our skin, how to keep it healthy or what to do. A lot of information for you on the skin and how to take care of it. We're talking with Dr. Meredith Overholt, board-certified dermatologist, skin specialist, dealing with abnormalities in the skin every single day, spots on the skin. Are they abnormal or are they okay? Meredith, welcome to the Dr. Bob Show.
Thanks.
How do you determine if somebody has a spot on the skin, if it's going to be a good one or a bad one?
Well, visually, there are certainly some clues. One of the things I tell patients all the time is if they notice a new spot, do a quick inventory. See if they can find several others who look just like it. Melanomas don't come in 12s. Okay, so there's safety in numbers. If you have a type of spot that you have several of them, that's generally a better sign. You know, when you see something that's unusual, though, that doesn't automatically make it cancer. In any group of spots, you've got to have one that's the biggest. But then you would want to watch it and see what it does. If it's growing or changing, that combination is known as the ugly duckling sign. I don't like anything you've got one of if it's growing or changing.
So tell me some interesting facts about the skin. You deal with the skin every day, and it's not as simple as people would think. And I was looking at some of the multiple diagnoses that you have to learn in order to explain to people what they've got. So what are some facts on the skin?
Well, certainly everyone always says it's the largest organ in the body.
So what do they mean by that, the largest organ?
Just by weight.
And surface area?
Yeah,
it's a
certainly
huge
that,
amount.
a huge organ, but also many people consider it to be a part of the immune system. So, you know, as an immunologist yourself, you know that the skin is heavily involved with that. A lot of people don't really think about it that way, but when you think about it, the skin is between us and the outside world. It's a barrier layer, so it's where our body comes in contact with potential trouble. So it's where the immune system has to be very, very heavily enforced.
And so when you get a cut on the skin, the immune system has a defense mechanism where it doesn't get infected, turns red, brings blood cells in there, and then other chemicals that help heal the process.
Certainly true.
So how do you know how deep the lesion is and what we need to do about it? When you've seen it before 100 times, or everyone's a new person with new skin?
Well, there are certainly some common benign skin growths that people come in to see us about, or certainly common skin growths. People come in, they don't necessarily know that they're malignant or benign. Certainly, since we see these all day, every day, we can be very helpful in being able to help them determine which of those is true. There are some skin lesions that present up on the surface of the skin. And so when we're looking directly at those, we can be pretty sure of what we're looking at. That, I have to say, isn't always as easy as it sounds. You know, many times by the time I see a skin lesion, it's been scratched or rubbed or picked at or applied several different medications to or frozen with over-the-counter freezes, etc. So I often see a spot that can look completely different than how it started.
Anything we can do to make it difficult on the doctor.
That's right.
So the outside surface of the skin, I would infer, therefore, that there are some different layers.
Yes.
What are they?
Yes, so it's the epidermis, or the outermost layer of the skin, okay?
Epidermis.
Yes. And then the dermis, or middle layer, okay?
That's the meat of the skin?
And then the subcutaneous region, which is mostly the fat, and then muscle going on down from there.
So that subcutaneous part is one we want to get rid of a lot of it. Don't want to have too much fat.
It's one way to look at it.
Okay, so there are different layers with different functions and different responsibilities. Let's stay up on the very top, where you've got something on top of it, and you've got to decide if it's a good one or a bad one. How do you decide?
Well, again, some of it is knowing that if I see a spot and I see that the patient has any number of them that look identical, that's always a good sign. And again, a lot of it is pattern recognition. I'm used to looking for specific types of things. There's a lot of common benign growths. The things that people would be fairly familiar with might be moles. Okay, so there are the flesh-colored raised type moles, or flatter, darker moles. There are skin tags, which often occur in locations where the skin rubs together. Okay.
Yeah, they're just sort of tags of skin coming together. Do those turn malignant, or do
No,
you need to
not
take them
really.
off, or sometimes you think they're ugly and you want them off?
It's benign skin growth that is really the crux of the matter. Is it really a danger? Obviously, if we're saying it's benign generally means that it doesn't have any potential to become cancerous, right? Okay, other than that though, it's not that a benign skin growth can't cause problems. Sometimes they'll occur in locations where a shoulder harness goes, or glasses rest, or a waistband goes, or bras rub, and people really just can't go without those things necessarily. So sometimes skin lesions can need to go because they're problematic. They get rubbed and irritated and can become quite uncomfortable.
If you get a benign lesion, one that usually doesn't cause trouble, and you beat it to death with elastic garments, and they rub on there and it begins to bleed, or you comb your hair and it begins to bleed one little spot that you've got there, is that a sign you better have somebody look at it?
Well, I think if you can be absolutely certain that the lesion had been there for a long time without any problem, and that what it looks like now is because of what you did to it, that's pretty self-explanatory. But some of the worst looking spots that I've ever seen that people have come in with that walked in the door and looked very, very frightening, in fact, to me on initial exam, were just a benign growth who got in the wrong place at the wrong time. It happens all the time. So
are those, do you have to get a biopsy? Do you have to take a little piece of the tissue?
It depends. Sometimes if there's any question at all that it might be malignant, then I will definitely go ahead and, as I remove it, go ahead and tell the patient that since I'm not 100% positive of what it is, that it needs to be examined by a pathologist.
So the one that was the biggest and baddest looking and everything, could you still tell it was going to be benign and you didn't need a biopsy, or did you get a biopsy on that one?
I remember that one exactly. But yes, I'm going to err on the side of caution, certainly, and send it if I feel like it's necessary.
Sure. How's a biopsy done?
Well, there are a couple different most common ways of doing that. We always numb them up, usually with lidocaine. Okay. Sometimes people can be sensitive to lidocaine. If that's the case, we have some alternatives. But clean the skin, numb it. And most commonly, we do a shave biopsy, which is just a flat blade that's used to take the lesion off basically at skin level. Okay.
You did that for me one time, and I didn't know you were doing anything.
Yeah,
it was just like,
pretty quick and easy.
When are you going to start?
Yeah. Then sometimes we use a tool called a punch, which looks like a little cookie cutter. And that's when we think the lesion might be a little bit deeper in the skin, or sometimes that's used for rashes too. So those have to typically be stitched afterwards. It's like taking a little core sample. You're getting a little outer, middle, and deeper layer of the skin when you do that.
And you have to send that off put it in some preservative and
Right.
send it to a pathologist.
Yes.
And he comes back and gives you the details of what's in the skin.
Of course.
And those details are going to tell you if it's good or bad.
Right.
So there's a lot of superficial skin lesions. We're going to be talking specifically some of those lesions and whether we think they're precancerous or benign or cancerous. You'll want to stay tuned for this. We're talking with Dr. Meredith Overholt, board-certified dermatologist. We've been talking about superficial skin spots. Skin has different layers, and all of those have different personalities and responsibilities. And then we began talking about a biopsy. You can either cut a little sliver off, or you can do a punch biopsy, like you're cutting into a cookie dough, and you send it off for reports. And that goes to the pathologist, who tells you what he sees. Can you rely on his report as far as benign or malignant, or he tells you generalities?
No, he's usually pretty specific about whether something's benign or malignant. You know, there's certainly what we call clinico-pathologic correlation, which means that...
Clinico-pathologic correlation.
Yeah, well, that means I tell him what I think it looks most like, and anything pertinent about the patient that I think might be helpful as far as their history, whether their immune system is compromised, for example, because that can affect the way that the tissue looks, okay? And then he'll look through it, and if he sees what he thinks is cancer, and lets us know. Mm-hmm.
How would you explain the word immunocompromised? You know, I know what that is, but it's big, long words.
Well, just an immune system that's not functioning normally generally is, you know, they can be overdoing it or underdoing it, okay? People who have autoimmune disease almost have hyper-functioning immune systems, right? But I'm really speaking more of patients who have lowered immune systems. For example, a transplant patient or somebody going through chemotherapy. You know, when that is the case, the immune system is not as strong as it normally would be, and the pathologist might be expecting to see inflammation around that tumor that he's not seeing. So if he knows in advance that that's a problem, he can kind of keep that in mind when he's looking at the tissue.
When I'm talking with you, a physician, a skin specialist, and we talk about AKs, SKs, what is an SK, seborrheic keratosis? What is that?
Well, a keratosis in Latin means a rough spot, okay? So there are the two major types, the actinic keratosis or precancer, and then the more common seborrheic keratosis. These are the hereditary benign spots that increase in number with birthdays and don't become malignant.
With birthdays. So as you get older...
That's a nicer way of saying that they...
as you get older, where are they usually located?
They can be anywhere on the body.
And what do they look like?
They can often be they're the most common reason for a visit to the dermatologist when somebody's worried about cancer but doesn't have it. Okay, because they can be asymmetrical, irregularly bordered, irregularly colored, or very dark in color. They're often bigger than 6 millimeters, and if, in case you didn't catch it, that was the ABCD of melanoma, so they can have a lot of the same characteristics of malignant tumors. You know, growing, changing, itching, bleeding, they can do all of those, so they can share a lot of the same signs and symptoms that a melanoma has, and yet be completely, totally benign. Okay.
Is that easy? Can you feel them and sort of say, I think that's a...
Well, they're keratosis, so they're a rough spot by definition, so they often have a velvety or scaly surface to them, especially on the trunk. On the extremities, oftentimes they'll look almost more like a drip of wax. You can tell that they have a texture to them, but it's not truly scale, per se.
In general, if somebody finds a seborrheic keratotic lesion, they don't think it's all that pretty, and they may want you to take it off. Do you take them, any dangers in taking them off?
Well, you know, they may have reasons other than just not being pretty. Again, sometimes they will show up in really bad locations, and since they're raised above the skin, they're pretty easy to traumatize, and I'm not sure why, but once they, get traumatized and start becoming inflamed and irritated, they'll swell, and then they're just even easier to irritate. So it does end up being kind of a circular motion. So even insurance companies recognize that these can be problematic and will pay for me to treat them. So cryotherapy is probably the most common way to treat them. This is a cryac, okay, which usually contains liquid nitrogen, and that's the most common way to treat those.
And when you spray the liquid nitrogen, what's it like? Could you spray my hand right there, just anywhere you want? It'd be okay.
There's no liquid nitrogen in it, but we can pretend.
So you spray it right there, and then it freezes the lesion?
Yes, it does really two things. One is that it's 196 degrees below 0 Celsius.
Whoa.
Okay, so it's going to freeze the water in the epidermal skin cells, which, you know, if you remember from chemistry, that if most things contract when they freeze, but water expands because of polar bonds, so that does bad things to your cell membranes. So it's traumatic to the cells, but it also creates a blister. Okay, and a blister is basically the epidermis lifting up off the dermis. The nice part about that is that I'm creating a blister, which is still intact skin, whereas if I cut something off, I create a wound. Okay, so freezing is preferable in many cases over cutting something off because it's a safer way of treating. You don't have a risk of infection with freezing.
And over the years, as I've seen people come in that have been treated with the cryotherapy, the cold therapy, I will ask them, well, did it hurt? And they say, no, maybe a little sting if you want to really be a sissy.
Well, it depends upon what location on the body. You know, sometimes people have had warts frozen on their fingertips as a child, and they remember that as a fairly painful experience. But when you're freezing a large seborrheic keratosis on the back of the shoulder, you're right, it's generally not too bad.
Let's go to some other lesions that are benign, that are treatable. Warts, nevi, epidermal cysts, which one? Talk to me about one of those.
Well, certainly moles are a common thing people come in wanting to have removed. Moles will generally start off flat and dark, and then many will raise up over time. It's called maturation, so they'll raise up, lighten in color, and become raised flesh-colored moles. And it's funny, sometimes people are more bothered by the raised flesh-colored moles than they are by the flat, dark ones, even though those are the ones that are more potentially dangerous. Once they become raised and flesh-colored, the risk is actually pretty small. But when they're raised, they're more in the way. Okay, so sometimes people, again, will want those removed because they're uncomfortable, or sometimes because they're unsightly. Insurance is, check on your, check with your local doctor, because I think insurance rules can probably vary on this in different locations. But, a lot of the times insurance companies will pay to remove them if they're problematic, but not otherwise.
So you're very generous and very kind when you talk about the ability to somebody to allow you to do what you think should be done, but that has good benefits too. Yes. Insurance people tell us you just can't go hog wild.
Yeah, you can't remove everything for everybody. That oftentimes they are cosmetic, and sometimes people are surprised to hear that when I would remove a mole that I'd leave a scar. I'm happy to think that they think I have a magic wand in my office, but when I cut something off the skin, I generally do leave a scar. The question is more with a benign growth in particular, am I going to leave you with something that looks worse than what you came in with? And we're pretty good at being able to tell which would be the case.
I went to you one time and I had a little bitty lesion that was a basal cell, and you removed it and put sutures in, and I can't find that area for love or money. It was such a beautiful job, and I was so impressed.
Sometimes that's luck and location. Some locations lend themselves better. For example, if that mole is within a natural line on the neck where everyone has natural lines, I can hide that line in a line, and it looks great, and people think I'm a wonderful surgeon. If the mole is right here over the ball of the cheek or the chin, there's no lines to hide that line in, so the scar will be more obvious. So some of it has to do with location.
So I'll see, when I'm examining people, lumps on their back. Sometimes they're raised fairly big, movable, you know basically what they are. And some will have a little core like a comedone on that. Let's talk about those when we come back.
Okay.
A lot more information. We're talking with Dr. Meredith Overholt, board-certified dermatologist, skin specialist, and we're learning about some of the problems that are on the outside of the skin, what we can do for those. And I was talking with Dr. Overholt, and I said, well, what do you do about the back? So I don't have eyes in the back of my head. How do people know if they've got a bad lesion on their back?
Well, that's hard, and oftentimes people will come in specifically because they can't really see something specific. So we take examining locations like that very seriously. But if you have someone who can even help, a lot of times if people are given, they want to give somebody else the responsibility of watching their back for them, that makes them feel uncomfortable. So one of my favorite tricks is to have them stand back from their partner's back with a cell phone camera and just fill the frame of the camera with the back and take a good photo. And then you can put a note in your calendar in 6 months, time to look at back, pull up the picture, and all they have to do is look side to side. And that way, if in the photograph this was the biggest spot and now that's the biggest spot, it grew, so that's an easy way to tell if you have something that's growing or changing.
So cell phones and the pictures they take as far as rashes and spots and
Can
lumps
be hugely
and
helpful.
Yeah, just unbelievably so. What about somebody, a good friend of mine, playing racquetball, and so his back was to somebody and they saw a spot in his back and they said, you better get that checked. And it ended up being a melanoma. So when somebody else sees a spot on the back and says, you need to get it looked at, what's going through the mind of the person? It didn't bother me.
It can be very anxiety provoking depending upon that person. Sometimes they've had somebody in their family who's died of cancer, and it can be very, very worrisome to hear that from somebody. But we've taken care of a lot of those that turned out to be something significant. So I do think it's something if you see something on someone that they might not know that they have, it is your responsibility to say so and to tell them, I don't know what that is, but it may be something that you need to get checked.
Is there a total body examination where you have to look at the head and the nose and the outside of the body all the way down to your toes? Are those helpful? Can they be helpful? Are they something everybody should do?
They can be helpful. Oftentimes we'll do one for a patient who is perhaps new to the practice. It gives us a chance to show them what they do have and don't have, so that we can have a little bit of a language together about what to watch for, etc. And see what lesions might be precancers, might need a little bit of work that day, or what things that they might want to watch, like we said with the cell phone camera, etc. I don't know that it's something that everybody needs to do. In fact, it's a risk factor based situation. So if you have a patient who's dark haired and dark eyed and doesn't burn ever, and doesn't ever get out and get in the sun, they work inside all the time, and there's no personal or family history of skin cancer, that person's not somebody who really needs to come regularly to the dermatologist.
On the other hand, the person who loves the beach and loves the sun and loves to exercise
at least ought to get
outside.
checked once, just to see and have a risk factor assessment done. It's not something where we need to do this every day. It's funny how we sometimes see that on the news. We'll have somebody in New York City who is talking about how everyone needs to have a skin exam once a year, but that's because there are 187 dermatologists per block in New York City. I'm teasing, but whereas some states have 6 or 8 dermatologists in the entirety of their state, so it's not a nationwide absolute.
But I think talking to patients saying, hey, the sun can be the cause of wrinkles and sunburns and eventually skin cancer and all that. The education that you give patients really is extremely helpful.
We certainly hope so.
No, well, it is. I've had people go, I've got to go see Dr. Meredith Overholt. Says she's going to be mad at me because I had a sunburn last week or something like that. I think that's wonderful that you do that, and you tell people that there's things they can do to keep your skin healthy, looking better. Eventually, the sun's going to wrinkle your skin if you don't take good care of it. Meredith, you're a great teacher. I love having you as a guest here, and thank you for taking time to come to the Dr. Bob Show.
Sure.
And remember, the 4 things that we like are going to help your skin. So if you're exercising, put on sunscreen when you go out and exercise. Don't get dehydrated. Drink a lot of fluids. Be sure you get 7.5 hours sleep. When you get 7.5 hours sleep, you'll feel better. Your skin will do better. You'll look better. You won't get so skeletoid looking if you hydrate and you eat properly. Be sure that you are eating properly. Eat less food, no fried fatty foods, and stay away from the, you know what they are, so be careful. And if you have to eat some of those, make the volume very, very small. Make it where, okay, I want that piece of fried whatever it is, or a French fry. Just eat a French fry, but don't eat 2 bags. And most of all, what is it we like in the Dr. Bob Show? It's that laughter in your life. Studies, medical studies have shown that if you laugh a lot, you will stay healthier. Your immune system will work better. Your skin will do better, and you'll be healthier.